Hello, students. This is Faizan Mirza. We are discussing the topic of gene therapy in genetic technology. So, gene therapy basically is a technique to deliver a working copy of the gene into a cell and make the gene work in that cell which initially was lacking that gene or that allele. When the gene is expressed in that cell, the polypeptide of that gene or that allele would be made and the cell would end up having the working copy. But the case is that only recessive disorders can be treated. Dominant disorders cannot be treated in gene therapy because the dominant disorder would still have the dominant allele in the cell, irrespective of how many recessive alleles we keep on putting through any vector into the disease cell. Viruses, liposomes, these are the mainly used vectors to deliver gene or gene product in gene therapy into the affected cell. For example, this is the affected cell, the host cell. You can see these are the chromosomes, or you can say the DNA molecules present in the host cell, which have a faulty gene or they have a faulty allele of the gene, or probably they are missing that gene altogether. So what do? You take a virus. In that virus, the nucleic acid is already there. You add your desired gene in the virus. So this is the viral DNA, and the viral DNA here I am representing it with the black color, and I am representing this red added gene to the which is being added to the viral DNA. This is the desired gene that I want or that we want to be incorporated into this host cell. So this gene is added to the existing genome of the virus. This DNA becomes the recombinant DNA. Now the recombinant DNA is inserted back into the virus. So this virus will become our vector. We will allow our vector, the transgenic virus, this vector to go and transfect the host cell. In doing so, it would deliver its nucleic acids into the host cell. When the nucleic acid goes into the host cell, this is the viral nucleic acid. When it goes in, the viral nucleic acid, since it was having our desired gene added to it, since it was the recombinant DNA, so the gene got incorporated into the genome of this host cell. So what have we done? We have carried out gene therapy. Working copy of the gene is already provided to the host cell. The applications of this have been in SCID and treatment of the bubble babies. SCID is severe combined immune deficiency disease. In this, patients lack enzyme ADA since the gene is missing. ADA is the enzyme which is required for proper synthesis of T cell functioning proteins and T cell functioning factors. So actually, the immunity cannot function. The immune system cannot function without appropriate functioning of the T cell. So ADA enzyme is required for appropriate functioning of these T cells. If an individual lack ADA, the T cells cannot function appropriately, and such babies they get fatally ill because of infections. The infections that these babies get, they can be fatal, and they in fact are fatal, and the babies they die in infancy. For protection for these babies who are lacking ADA, they are prevented against infection at very early stage of their infancy by keeping them in bubbles, and that's why they are called as bubble babies. The idea of these bubbles is to prevent the pathogens or the microorganisms which can enter their body from their environment. So the idea of bubble babies is to keep them protected from the surrounding environment. But this cannot go forever. So the disease of SCID ends up causing the death of the baby. Gene therapy comes to help. So ADA gene, if you add this into a virus and add the virus to the host cell, the gene can be delivered to the host cell. Retrovirus was used initially. Retrovirus was used to deliver the ADA gene in the same way as I explained here into the T cell. So this was the T cell, this was the retrovirus. So in this way, the T cell ended up getting the gene for ADA, and SCID disease got cured. But leukemia followed. After a few years, these babies who were treated for SCID, they ended up having leukemia, which is the cancer of white blood cells. Why was that so? Because the retrovirus which was used, although it delivered the ADA gene, the problem that came after that was that it inserted its own DNA randomly into the existing genome of the host cell. And in doing so, it triggered oncogenes. And you know when oncogenes get triggered, it caused cancer, so cancer followed. The next step was that retroviruses were not suitable, so lentivirus was used, but lentivirus again ended up inserting some genes in the random manner in the same way as retroviruses were doing. So the lentivirus were also rendered useless, since they and retrovirus, they both were doing the same thing. They would deliver the gene of interest to the host cell, but they would insert their own DNA into the existing genome of the cell randomly, and this would trigger oncogenes and cancer would follow. What came for help? Another virus, AAV, adeno-associated virus. This is the virus which has successfully been used in gene therapy now. You add your desired gene into the AAV. This is the AAV virus, for example. You add your gene here. You allow the virus to go and insert the nucleic acid with the added gene into the host cell. So again, you are following the same gene therapy protocol. First of all, retroviruses were used, then lentivirus, and now adeno-associated virus. So with adeno-associated virus, immense hope have come in gene therapy, and successfully diseases have been cured. There are various ethical issues which are raised by people across the globe for genetic screening, that who should get tested, who would decide who would get tested, and why are the people reluctant for getting screened for genes to begin with. So one very important factor is that gene testing is an expensive protocol. Moreover, if we talk about other features, so some people actually fear needles and they are afraid of blood collection or sample collection for this particular protocol or performance of this test. Some people might be fearful of the outcome of what if they actually are suffering from that disease or are the carriers of that disorder. So this is this big if question. Furthermore, some people might be concerned about the social fallout or the implications of getting the disease and the stigma associated with it. Plus, economic concerns that a person may have, or the job related issues that a person may think of because of coming across this disease. And as well as one very important factor is that the person may find this gene testing to be useless, since the disorder cannot be treated since it's at the gene level, and probably the cure is not there, which is one of the main reason when we are talking about a person who's asked to go and get tested for Huntington. So the person knows that there actually is no cure for Huntington, since it's a dominant disorder. So even gene therapy cannot work there. So these are the reasons why gene therapy is not very successful in many cases, because genetic screening cannot be performed, and many people who are afraid of genetic screening, obviously this until unless genetic screening is carried out, you cannot go further. Now, the next thing that we are discussing here is liposomes and how they are used as vectors. What are liposomes? Liposomes are the vesicles of phospholipids. They are very similar to Golgi vesicles. And these are made from phospholipids, and these vesicles can carry the nucleic acid that the gene is actually there. So you can deliver this gene or the product of the gene, which is, for example, the channel proteins impregnated or incorporated on the membrane of phospholipids here. And in this way, the gene or the gene product can be delivered to the host cell, and the host cell will take up these liposomes by the process of endocytosis or phagocytosis, and the gene will be delivered inside the cell. And not only the gene will be delivered, the gene product can be delivered to the cell in the very same way. Gene therapy, which is applied in medicine, there are two main areas in which it is done: somatic gene therapy or germ cell gene therapy. Somatic gene therapy, it aims at treating genetic disorders of a faulty or missing allele in diploid cell of an organism who is suffering from the disease. Since it's somatic means diploid cell. Germ cell gene therapy, germ means germline, not the germs. It means germline, the gametes. So it aims at inserting a normal allele in a gamete of an organism who can pass on the abnormal allele to the offspring otherwise. So you treat the genetic disorder at the level of gamete in the germ cell, and this is called as germ cell gene therapy. We have to discuss a disease called cystic fibrosis. Now, what is cystic fibrosis? Also abbreviated as CF. This is a disease which can be managed with gene therapy. So, first of all, we have to go through the disease factors, that what actually is happening in this disease, and then we can discuss the idea of how gene therapy works here. So CFTR is a gene on chromosome number 7. It codes for its normal allele is a dominant allele, and the faulty allele is a recessive allele. What is the gene doing? What is CFTR gene doing? CFTR gene codes for a protein, a transmembrane protein or a membrane protein that can go and incorporate itself in the phospholipid bilayer of mucus producing cells. So let's suppose if this is a mucus producing cell and this produces mucus. So this mucus which is produced here, this is the outside the cell, this is inside the cell. So mucus production is going on in this cell. When mucus is produced, so the mucus initially is very sticky. And why is that so? Because it's having all the proteins and carbohydrate. Mucin protein is here, which is actually a very sticky protein. The CFTR gene, which is present in the cell, will code for a protein called CFTR. This protein is a transmembrane protein channel which incorporates itself in the cell membrane of this particular mucus-producing cell. The function of this CFTR channel is actually a chloride transport protein channel. So it functions by pushing out or allowing the chloride ions to go out. So when chloride ions go out from the cell, they mix up with mucus. When they mix up with mucus, they make this region hyperosmotic or hypertonic. As a result, the cell lose water. When cell lose water, this mucus, it becomes diluted, and the diluted mucus can then easily be lubricated and it can move ahead across in this region. It is easy to flow. So people with normal CFTR or who are homozygous dominant or even heterozygous dominant for this normal allele, which is dominant allele, which is of CFTR gene, they have the normal CFTR protein. So their mucus is well lubricated, it is easy to move, it lines up all the mucus linings in the body organs, primarily the lungs, the pancreas, the digestive tract, the reproductive tract. All these ducts, all the tubules in these, they are lined by mucus membranes, and they have a lot of mucus present as well. But people who are homozygous recessive for this trait, they have a faulty allele. They have 2 copies of the faulty allele, so they lack CFTR. They lack the CFTR membrane protein, so when the protein is not there, the mucus that comes out, it will be very sticky mucus since chloride ions cannot combine with it and water cannot be drawn out. So sticky mucus blocks the ducts eventually. It gets colonized by bacteria in lungs, and it blocks pancreas, it blocks reproductive system. The lung mucus, obviously when it gets colonized by bacteria, it becomes prone to infections and difficulty in breathing. The hemoglobin saturation in such people with oxygen is very low. So they have to keep a continuous oxygen cylinder or a portable device that can deliver oxygen into their nose so that their blood is well oxygenated. What can further follow? Pancreas can undergo inflammation because of this blockage, and even they are reproductively sterile in their reproductive system. The ducts there, be it male or female, the person will be sterile and the ducts get blocked by this sticky mucus. A sweat test is a quick way to test the person for CFTR, and in this sweat test, rather than going for a gene testing, you can actually easily go for a sweat test. So in this sweat test, cystic fibrosis is actually diagnosed by the concentration of salt present in the sweat of the individual. So these people actually have a highly concentrated sweat in their skin. So that's actually they have very salty sweat. So that's the diagnosis for this, that the person is actually suffering from cystic fibrosis. So how liposomes are used to treat cystic fibrosis? So what do? You take this gene. This is the DNA segment on chromosome 7, normal CFTR gene that codes for chloride membrane protein. You take plasmid as a vector, the bacterial plasmid. You use both of them. You add a nick here using restriction enzyme. You cut the plasmid. You cut the gene with the same restriction enzyme. They both are added together by DNA ligase. So you get the recombinant DNA. The recombinant DNA is then coated with liposomes, so phospholipid vesicles. So when you coat it here, it becomes a more you can say easy for it to be transported into the host cell. So this liposome mixture, or you can say liposome rDNA, is actually given as an aerosol spray to the patient. So when this aerosol spray, it goes to the respiratory tract of this individual who actually was suffering from cystic fibrosis, since the lungs could not get enough well lubricated mucus. So when this liposome rDNA aerosol spray goes into these lungs, the patient of cystic fibrosis will be getting a lot of benefit from it. And how so? Because here this person, he or she received this treatment. So liposome rDNA complex, it fuses with the epithelial cells of the lung. This is the epithelial cell present inside the lung of this individual. So you just magnify it. So this liposome and this rDNA vector with the gene of CFTR, it comes close to the epithelial cell. The R plasmid enters the cytoplasm and then the nucleus. So this goes to the cytoplasm, it goes to the nucleus. The CFTR gene is expressed into mRNA, transcription occurs, mRNA comes out, the mRNA undergoes translation, and a chloride membrane protein channel is made by translation. So the polypeptide which is made here is a protein channel. So this transport protein goes to the membrane. When it goes to the membrane, it gets incorporated into the epithelial cell lining, and chloride ions can move out of these cells from this. So once the chloride ions can go out, water can go out, and water and chloride ion can mix with water, and the person can get well lubricated mucus. The effect of this CFTR protein in such treatment is not very long lived. It's a short lived, you can say, resolution. And why is that so? Because the epithelial cells are constantly replaced, they are constantly sloughed off. New cells are made from the basal cells which are already there in the lungs, or the stem cells which are present there. Since you are not treating the stem cells in the respiratory tract, you are just treating already differentiated and grown up cells. So the gene is being incorporated into grown up cells. So when the cells divide, it's not necessary that the gene will be passed on to the next cell, since the next cell will be produced from a cell which is having the faulty allele. So the same treatment needs to be repeated on regular basis, and regular doses are required to make sure that this treatment works. So this is how the respiratory system can be managed with the patients who are suffering from cystic fibrosis. However, the reproductive system and the systems which are, for example, the pancreatitis, these cannot be managed with such aerosol sprays of liposome and rDNA, because you cannot incorporate the gene in the pancreas or in the reproductive glands, because it's not accessible through the nasal passage or the oral passage. So that's it from my side for now. Thank you so much.